Hi, I'm Dr. Gordon Wong. Welcome to the Health Information Series. In this video, I'm going to talk about technologies that can be used to sustain life. It is a companion to another video that I made on how to legally prepare healthcare directives. When we prepare healthcare directives, we need to write down what we want or not want to be done when we can no longer make decisions. However, to know what we want or not want, we must understand the available technologies, and this video will explain some of them. When I talk about health-sustaining technologies, I am referring to technologies that, if not used, the patient will likely die within a short period of time, like a few minutes to a few weeks. When preparing the healthcare directives, we need to specify which technology we want or do not want to use. Some of these technologies are well known and familiar to most patients. Others are fairly new. When I describe a technology, I'll focus on how it would affect the patient's quality of life. I won't go into much detail on the scientific and pathophysiology side of the technology. The first one is intravenous fluid. IV fluid is very well known to almost everybody. Nowadays, you see athletes getting an IV during the middle of a game if they're dehydrated. Without fluid, we cannot survive. So it's almost routine that a patient will get IV fluid while in the hospital. As you know, IV fluid is pretty straightforward. There's a small needle, you put in a catheter into the vein, and then you supply the fluid. Very minimum discomfort to the patient. And the patient, if alert, can move around, either holding the pole and carrying it with him or her, or disconnect the IV, move around, and then hook it back. All required is to change the catheter maybe once every few days. Very benign, minimum discomfort for the patient, but without IV fluid, a patient, if cannot drink, will die in a few days. The second technology, again, should be very familiar to most people. It is supplemental oxygen. If the patient requires some additional oxygen to function, we can deliver the oxygen either using a nasal cannula or a mask. Many patients with chronic lung diseases like COPD or lung cancer will require supplemental oxygen even when living at home. Supplying oxygen to patients used to be pretty inconvenient. We need a tank like this. When the oxygen is used up, we need a different tank. This tank is somewhat dangerous if we use oxygen at home. It increases the chance for fire, and it also increases the chance for an explosion. Nowadays, we have machines called an oxygen concentrator. It extracts oxygen from air, and you can just plug it into a wall and it will generate oxygen. Never runs out, no additional fire risk, very convenient. We even have portable versions that you can carry around if you need oxygen and you need to go out. Now, how long can you be on supplemental oxygen? If the concentration you're using is fairly low, like 30% or 40%, you can pretty much use it indefinitely and it won't cause much damage or inconvenience. Remember that air has an oxygen concentration of 21%. So if you need some additional oxygen, say 30% or 40%, it is very safe and pretty much no effect on the body. However, if you need a higher concentration of oxygen, you can only use it for about a month because high concentration level will actually damage the lung and other organs. And if you use it for more than a month, it will cause permanent damage to the body and chances are patient will not be able to survive on 100% oxygen for very long. The third technology, again, should be a very familiar one to most people. It is blood transfusion. If a patient has a major bleeding problem, then he or she will require blood transfusion to survive. The risk of blood transfusion is fairly minimum nowadays. Infectious diseases are the most severe problems associated with blood transfusion. However, now we are screening for major infectious agents like HIVs, hepatitis, and so on. Of course, we can't screen for everything, but if you don't get a blood transfusion, you will die. And if you get one, you have a very small chance of getting an infection. Definitely, you take it. But blood transfusion as a life-sustaining treatment is only a stopgap measure. You have to identify the source of bleeding. Otherwise, it won't do you much good, except buying you some time. Another well-known technology is cardiopulmonary resuscitation, or CPR. In the basic version of CPR, that's the version that we learn in first aid. When someone's heart suddenly stops beating, we try to compress it back into rhythm. We also do mouth-to-mouth breathing to help the patient get oxygen. Now we have a device called an external or automatic external defibrillator that can shock the heart back into rhythm. CPR is most useful during an accident. For example, in a drowning accident, there's a reasonable chance to save a patient if the patient suffers a cardiac event because of accident and the patient is otherwise healthy. However, for a senior patient with many chronic diseases, and when his or her heart suddenly stops beating and you perform CPR, the chance of saving a patient is very low. Furthermore, when you do CPR, you gotta compress very hard on the chest, and you almost have to break a few ribs, otherwise you're not compressing strong enough. For a young and healthy accident patient, this may be the price to pay to save the life, but for a senior patient with many chronic diseases, this is really questionable in terms of whether it's useful or not. There is an advanced version of CPR called Advanced Cardiovascular Life Support, ACLS. ACLS is usually performed in a hospital by healthcare professionals. In addition to doing basic CPR, healthcare professionals will inject medications into the patient to help restart the heart. However, for patients with chronic diseases, the chance of reviving the patient is only at about 10%. This is the chance that the patient's heart can be restarted. The chance that the patient can actually survive and walk out of the hospital is less than 2 or 3%. Usually, the patient may survive for a few more days, but the next time the heart stops beating, we won't be able to save the patient. So this is really just buying the patient a few more days. If the patient is already in the hospital and the blood pressure drops too low or the heart is not working well, we can use some medications to help increase the blood pressure and to help increase the heart's function. There are usually two reasons causing blood pressure to drop and the heart to become very weak: infection and heart failure. If it is an infection and we use these medications, we also give antibiotics to help fight the infection. Hopefully, when the infection is gone, the heart can recover and the patient can survive. But if the problem is caused by heart failure, then these medications will only sustain the patient for a few more days. Eventually, they'll stop working. Most of the time, when we use these medications, the patient's already in a coma, so it really doesn't cause any discomfort for the patient. For patients with a poor heart that affects its function, in recent years, there's a new technology called ventricular assist device, VAD. VAD is a pump that you connect to the blood vessels outside the heart, and the equipment is placed inside the chest of the patient. And then there are some wires connecting the device to an external battery and control system. The patient can wear the battery and the control and walk around. This device will assist the heart in pumping blood, giving time for the heart to recover or for the patient to wait for a heart transplant. It can be used for a fairly extended period of time. About 50% of patients receiving VAD are still alive after 1 year. The biggest risks to patients are blood clot and stroke. But because the patient can still move around with the device, the quality of life is reasonable. We have discussed the heart, so let's talk about the lung. The lung is for getting oxygen. Oxygen is required to create energy. Many conditions can cause breathing problem. For example, pneumonia or breathing in smokes during a fire will cause acute damage to the lung and cause the lung not to be able to exchange oxygen, or chronic diseases like COPD or lung cancer. We've already talked about breathing in oxygen. If that's not enough, then we need some more high-tech solutions. The first one I'm going to talk about is BiPAP. BiPAP is using a pump to force some air into the lung. If you have sleep apnea or you know someone with sleep apnea, you probably have seen the machine they use. They wear a mask to sleep at night. The machine will force some air into their lung and help them breathe better during sleep. BiPAP is similar to the CPAP machine, except it's more advanced. Like the CPAP, it really is not very uncomfortable for the patient. People using CPAP always say that the mask doesn't bother them at all. Similarly, for BiPAP, patients tolerate this device very well. However, it is also not a very effective device. It only produces marginal improvement to the patient. If the BiPAP is not effective, then you need to put the patient on a ventilator. When we first put patient on a ventilator, we put a tube into the patient's throat through the mouth and then connect it up to the machine. This is very uncomfortable for the patient, and we usually have to sedate the patient in order to place the tube. If a patient has to stay on the ventilator for an extended period of time, we usually open a hole in the patient's throat. This is called a tracheostomy. We'll connect the machine directly to this opening and not through a tube in the mouth. This is less uncomfortable for the patient. The patient can be awake. We even have portable device that the patient can carry and move around. The patient can eat, although cannot talk normally. If the patient wants to talk, he or she requires a special device. Nowadays, patients can live on ventilator for years. It is even possible for a patient to get off the ventilator and have the opening closed, although this is fairly uncommon. But even with a tracheostomy, breathing from a ventilator is still fairly uncomfortable. When I was in medical school, the school wanted us to know what it is like to be on a ventilator. So every student was asked to breathe through the machine and just take a few breaths. It's like someone pounding on your chest every time you breathe. Although not very painful, it is fairly uncomfortable. Although I guess after some time, patients can get used to it and it becomes tolerable. If the ventilator fails, now we have one more device to use. It's called the extracorporeal membrane oxygenation, or ECMO. With a ventilator, we pump air into the lung, but the lung still has to do the oxygen exchange. If the lung is severely damaged, it cannot exchange oxygen. With ECMO, we pump blood away from the body into the machine. The machine then oxygenates the blood and pumps it back into the body, completely bypassing the lung. This gives time for the lung to recover or buys time to get a lung transplant. However, this device can only be used for a short period of time. The biggest problem is blood clot. After some time, blood clot will likely occur that will cause either a stroke or a heart attack. We've talked about the heart and the lung. Let us talk about nutrition. When a patient is unable to eat, we need to provide some form of artificial nutrition. One way to do it is by using a tube through the patient's nose into the stomach and then supply artificial nutrition through the tube. This is fairly uncomfortable for the patient, and it is not uncommon for the patient trying to pull out the tube. Then it has to be reinserted again. If long-term artificial nutrition is needed, we can do a small procedure, put a tube directly into the patient's stomach, and then use the tube to feed the patient. This is much less uncomfortable for the patient. This technology is very commonly used in America. However, in Asia, I rarely see it used, and I don't know why. Having a tube going into the stomach is not very uncomfortable for the patient. In fact, the tube can stay there for a very long time. The patient can recover and be able to eat again, and we can just leave the tube there. We can just flush it daily to make sure that it is open and to clean it to prevent infection. Some patients may have a condition that they cannot digest food at all, such as acute pancreatitis. They cannot eat anything. In this case, we can provide what is called total parenteral nutrition. We put amino acid, electrolytes, sugar, fat, all kinds of nutrients into a bag, and then using a central line, directly put the nutrients into the patient's heart. We can use this technology to sustain the patient for a few months. For some conditions, that's enough time for the patient to recover. But this technology only works for a maximum of several months. A patient cannot live on TPN for too long a period. When we digest food, our body creates many toxic substances that must be excreted. That is the job of the kidney. Kidney failure is now a very common problem. When the kidney fails, the patient can at most live for a few weeks because of all the toxins building up. Fortunately, we have dialysis technologies that can remove the toxins from the body. Because of diabetes and hyperpressure and so on, most of us are fairly familiar with dialysis. There are two kinds of dialysis, hemodialysis and peritoneal dialysis. In hemodialysis, we connect the patient to a machine, draw the blood from the patient, run it through a machine to remove the toxins, and then put it back in the patient. Usually we do this 3 times a week. Each time the patient is connected to the machine for around 4 hours. Many dialysis patients can continue to work and do other things while they are not getting dialysis. Another kind of dialysis is peritoneal dialysis. In peritoneal dialysis, we make an opening into the patient's abdominal cavity. We then use a pump to pump in some solution. The solution will extract the toxins and be pumped out of the body. The patient can do this at home by himself or herself. He or she can even do this while sleeping. During the day, the patient can go out and work or do any other stuff. This gives the patient a much better quality of life. However, peritoneal dialysis is not suitable for everybody. The patient must be able to handle the equipment and the medication. The house can also not be too crowded. Whether on peritoneal dialysis or hemodialysis, a kidney failure patient can now live for many years. He or she must follow a very restricted diet, but otherwise can still have a relatively good quality of life. Let us summarize the technologies discussed. In this slide and the next several slides, I've summarized my comments on each technology. I have color-coded my opinions. Green means that, in my opinion, the technology is fairly benign and can be used without much hesitation. Yellow means that the technology offers certain advantages, but its use should be evaluated to compare the risk and the benefit. Red means that I think the technology only offers very limited usefulness for the patient. I will not repeat what I have said earlier. If you need more time to read the comments, just pause the video. Last but not least, I want to emphasize that we need to understand these technologies because we need to clearly state in our healthcare directives what we want and not want to be done to us when we are no longer able to express our wishes. This is very important in helping us control our own healthcare. Thank you for watching this video.